Hello, good morning, friends. And today we'll be discussing about nutritional assessment in surgical patients. So, before starting, I would like to thank Chandana Shri Ma'am for sharing the wonderful notes with us. I have shared the link for the notes in the description below, and these are very helpful notes for quick revision. And please like, share, and subscribe. So, without further delay, let's get started. So, how do we measure the nutritional status? Check कैसे करेंगे? So, firstly, anthropometry, which is the body weight, the first one, which reflects the body fluid balance, which changes day to day, and the nutritional status, which is over weeks to months. So, body weight reflects fluid balance and nutritional status. Fluid balance changes day to day, and nutritional status over weeks to months. So, ideal body weight in men, it should be at least 48 kg for the first 152 centimeter, and again add on 2.7 kg for every 2.5 centimeter of added height. In women, it should be 45 kg for first 152 centimeter and 2.3 kg for every 2.5 centimeter. Third is the lean body mass, which is the non-adipose tissue mass. It excludes mass from the acute shifts in the water content and helps at identifying the obesity. So body mass index, which is weight in kg per meter square, weight in kg divided by height per meter square. If it is less than 5 percentile, it is underweight. If it is more than 95 percentile, it is obese. Then we have skin fold thickness, which is checked with help of skin calipers. So index of distribution of body fat in the subcutaneous region. So it is subscapular where it is checked, truncal skin fold or triceps in the upper limb, and mid-arm circumference in the children. So this was all about anthropometric measures for measurement of nutrition. Now we come to the clinical imaging, where we have dual energy X-ray absorptiometry, that is DEXA, for monitoring of long-term nutritional progress. Measures the changes in the body composition, which includes lean body mass, fat mass, and bone density. Others like CT and USG will also be helpful. Lab assessment, which we have the biochemistry. The first one is the albumin, which is more than the 50% of total body protein, T half being 20 days, and it helps in detection of chronic malnutrition. तो क्रोनिक मालन्यूट्रिशन को डिटेक्ट और क्वांटिफाई करने में हेल्प करता है. अगर 3 ग्राम पर डेसीलीटर से कम है प्री ऑप लेवल, तो मॉर्बिडिटी का इंक्रीज रिस्क हो जाता है, 30-day मॉर्बिडिटी. ऑल्सो एल्ब्यूमिन नेगेटिव acute phase reactant है, so it is not reliable for assessing nutrition in acute illness or acute stress such as injury or infection. Added capillary leakage. So other elements or biochemical parameters are transferrin, prealbumin, which is more better marker for acute malnutrition because its half-life is 2 days. Then nitrogen balance. Then we have some immunological tests, that lymphocyte count. Decreased lymphocyte count will be seen in the malnourished patient. Delayed hypersensitivity, abnormal reaction to intradermal test. So it is based that immune system is deficient in patients with malnutrition. Now we come for evaluation of metabolism and energy requirements. So resting energy expenditure or basal energy expenditure. First one is the Harris-Benedict equation, where RE, that is resting energy expenditure, is equal to around BMR. So it is calculated by 66.5 plus 13.7 into weight in kg plus 5 into height in centimeter minus 6.7 into age in years for males, and in females it is 66.5 plus 9.6 into weight in kg plus 1.7 into height in centimeter minus 4.7 into age in years. So this will give us the caloric requirement. that is the resting energy expenditure. So the caloric requirement will be calculated with help of resting energy expenditure into activity factor, that is 1.2, into injury factor, that could be 0.3 to 0.6 depending on the severity of injury. Now we have one more method, that is indirect calorimetry, where we use oxygen consumption, that is VO2, and expired CO2, that is VCO2, and use measured via the tight fitting face mask and adapter in the mechanical ventilator circuit. Mechanical ventilation, during mechanical ventilation it can be used this method. So resting energy expenditure is calculated 1.44 into 3.9 into oxygen consumption plus 1.2, 1.1 into carbon dioxide expired. It is used in severe burns, ventilator dependent patients, spinal cord injury or coma patient, or morbidly obese patient. It also helps in measurement of the resting quotient, respiratory quotient, sorry. So nitrogen balance, second is the nitrogen balance. First was the resting energy expenditure. Now second is the nitrogen balance. It is helpful to monitor the adequacy of protein intake. So nitrogen balance is the total nitrogen intake minus total nitrogen loss. So nitrogen loss is equal to total urine urea nitrogen plus 2 gram per day in stool and skin. So 24-hour urinary nitrogen, urea nitrogen is equal to, how do we calculate that? Urea nitrogen. So urea nitrogen in mg per dl into urine output in ml per day or gram, divided by 1000 milligram mg into 100 ml. So its value will be in gram per day. So this was all about calculating the evaluation of metabolism and energy requirement. Now we'll be seeing the enteral nutrition or trophic feeds, synonymous to trophic feeds. So enteral nutrition, here normally we eat food by mouth, but sometimes due to any reason we are not able to take food, then we have to bypass the oral cavity and the esophagus to reach the functional GI tract from stomach. So here there is a means of nutritional support in patient where the functional GIT who cannot take enough nutrition orally, मतलब मुंह से नहीं ले पा रहे, to meet the caloric requirement. Maybe it is impossible due to injury, trauma in the face, inadequate due to lack of appetite, or is unsafe due to some GI condition or esophageal condition, etc. So in patients taking oral feeds, enteral nutrition may be initiated if 60% of the requirement cannot be met by oral route alone for more than 10 days. तो अगर पेशेंट का 60% से ज़्यादा फूड वो ले नहीं पा रहा है ओरल रूट से फॉर मोर देन 10 days, then we should think about enteral nutrition, and it may be supplemented if caloric requirement more than 60% cannot be met by enteral nutrition alone. तो enteral nutrition को भी सप्लीमेंट करना पड़ सकता है अगर उससे उसका कैलोरिक पेशेंट का कैलोरिक रिक्वायरमेंट पूरा नहीं हो रहा है. सो व्हाट आर द एडवांटेज? द एडवांटेज इज लोअर कॉस्ट, सस्ता रहेगा, डिक्रीज रिस्क ऑफ आईवी रूट कॉम्प्लिकेशन, थ्रोम्बोफ्लेबाइटिस, प्रिवेंट्स reduces consequences of prolonged GI tract disease or disuse, sorry, prevents reduce consequences of prolonged GI tract disuse. मतलब यूज नहीं करें GI tract को तो उसके वजह से क्या क्या इशू हो सकता है. तो prolonged GI disuse का consequences क्या क्या है? डिक्रीज प्रोडक्शन ऑफ soluble IgA, तो इम्यूनिटी अफेक्ट हो रही है, डिक्रीज प्रोडक्शन ऑफ साइटोकाइंस, बैक्टीरियल ओवरग्रोथ, तो इन्फेक्शन हो सकता है, ऑल्टरनेशन इन म्यूकोजल बैरियर एंड डिफेंसेस, तो म्यूकोजल डिफेंस बैरियर वीक हो सकता है, रिजल्टिंग इन इन्फेक्शन एंड अल्टर्ड गट माइक्रोबायोटा. सो जो हमारे गट का नेचुरल बैक्टीरिया है वो अफेक्ट हो जाएगा एंड इट मे रिजल्ट इन इन्फेक्शन लाइक स्ट्रेप pseudomembranous colitis. So gut bacteria, bacterial fermentation of polysaccharides will result that includes dietary fiber. So it supports the normal gut flora and produces short chain fatty acid, which include acetoacetate and butyrate, which is preferred fuel for colonic mucosal cells, which is important for the mucosal integrity. So गट बैक्टीरिया जो हमारे डाइट में पॉलीसैकेराइड होता है फाइबर्स, उसको फर्मेंट करके गट के फ्लोरा को भी सपोर्ट करता है. ऑल्सो वो शॉर्ट चेन फैटी एसिड बनाता है एसिटोएस्टेट एंड ब्यूटाइरेट, which is fuel for the colonic mucosal cell and is important for the mucosal integrity. यानी mucosal cell ठीक रहेंगे इसलिए वो ज़रूरी है short chain fatty acid like acetoacetate. Enteral nutrition is recommended as a first choice of nutritional support in patients who can tolerate it. So it is important that if the patient can tolerate, then it should be the first choice. So if the patient can take orally, that is best. If the patient cannot take orally, then we can think of enteral nutrition, where we can bypass the mouth and the esophagus reaching the stomach. So that will be best because then there will be no GI disuse issues. So what are the contraindication? If the patient is having intractable vomiting and diarrhea which is refractory to medical management, मतलब उल्टी और लूज स्टूल्स हो रहा है जो ट्रीट नहीं हो पा रहा है, पैरालिटिक इलियस, बॉवल काम नहीं कर रहा है, हाई आउटपुट इंटेस्टिनल फिशुला which is too distal to bypass by the feeding tube, GI obstruction और ischemia, diffuse peritonitis, बॉवल ऑब्स्ट्रक्ट हो गया, ब्लीडिंग कॉम्प्रोमाइज हो गई, इन्फेक्शन है बहुत ज़्यादा, पेरिटोनाइटिस है, देन सीवियर शॉक एंड हीमोडायनेमिक इंस्टेबिलिटी, सीवियर GI हेमरेज, ब्लीडिंग हो रही है, सीवियर शॉर्ट बॉल सिंड्रोम वेयर देयर इज लेस देन 100 centimeter of ball remaining, then severe GI malabsorption. So these are some of the causes which are contraindicated for enteral support. So I have to think accordingly. So what are various strategies for enteral feeding? Early versus late feeding in the critically ill patient. Current recommendation is to start early enteral nutrition within 48 hours. So early full nutrition is generally avoided because it can increase infection. 80% of the caloric needs यानी 80% देंगे और धीरे धीरे बढ़ाएंगे over 3 to 4 days. अर्ली में प्रिजर्व करता है क्या, गट माइक्रोबायोटा एंड जो हमारा एपिथेलियल बैरियर है, म्यूकोजल बैरियर है, वो हेल्प रहता है. ठीक है. परमिसिव अंडर फीडिंग जिसमें हम अराउंड 1500 ऑफ किलो कैलोरी पर डे विथ 40 मिलीग्राम पर डे ऑफ प्रोटीन देते हैं, और हाइपोकैलोरिक न्यूट्रिशन विच इज रिकमेंडेड विच इज सिमिलर एंड अराउंड 1500 किलो कैलोरी per day plus 140 gram per day of protein, and it is specially recommended in the obese critically ill patient or normal weight patient with early acute period of critical illness. In the recovery period we can increase the caloric and protein inputs. Among intermittent and continuous is preferred generally because it has low complication rate and it promotes protein anabolism. So choice of enteral feeding, if it is for short term less than 4 weeks, then we have nasogastric, nasoduodenal, nasojejunal feed way through the NG tubes, and among these it is further divided. If the gastric emptying is okay, then we go for nasogastric method. If the gastric emptying or there is some gastric outlet obstruction or something like that, gastroparesis, then we go for nasoduodenal or nasojejunal. Similarly, in more than 4 weeks, sorry for the delay. So if we are considering enteral feeding for more than 4 weeks, depending on the gastric motility, if the gastric motility is all right and is no obstruction, we can go for gastrostomy through PEG, that is percutaneous endoscopic gastrostomy, fluoroscopic method or surgical method, could be open or lap. If there is gastroparesis or something like that, then we go for jejunostomy, that is PEG assisted jejunostomy, direct endoscopic, direct percutaneous endoscopic jejunostomy, or fluoroscopic or surgical, which would be open or lap. So these are some methods of routes of enteral feeding. So now we'll see them in detail. So nasoenteric routes, that is nasogastric, nasoduodenal or jejunal. So advantage of nasogastric, which we'll see in detail, it is simple access, easy to insert, आराम से काम कर सकते हैं, easy to monitor gastric pH and residual volume. Bolus feeding is also possible and suitable for short term use. What are some complications? So it will be through the nose. So rhinosinusitis, epistaxis, nasal necrosis. So these are some of the nasal complications. Then we have esophageal strictures or esophagitis, that is erosive esophagitis, and chances of frequent dislodgement. There will also be some risk of aspiration. So we have to reserve the NG tube use for patients with intact consciousness and mentation, and those having protective laryngeal reflexes. And it cannot be used for patient with significant gastroparesis or gastric outlet obstruction. So we have to consider the nasojejunal or duodenal feed. Now we see the nasoduodenal or nasojejunal tube. Feeding tube is advanced beyond the pyloric mechanism, and it's useful for patient with poor gastric emptying, reflux or aspiration risk. So the patient must have a functional GIT, but these some of the aspects have to be considered: poor gastric emptying, reflux and aspiration risk. So how do we place it? First is we can do blindly bedside, which is not reliable. Then other is fluoroscopic assistance. So here the fluoroscopic guided intubation past the pylorus, it has 90% success chance and 50% reach jejunum. And endoscopic, that is guided placement, that is also another option. Advantages: decreased aspiration risk. It will also allow for gastric decompression along with nasojejunal feeding. Disadvantages: similar: rhinosinusitis epistaxis, nasal necrosis, esophagitis stricture. So important here is it requires continuous infusion, cannot check the gastric residual except we have special port. Clogging, kinking and displacement, these are some of the disadvantages or issues. Small bowel feeding is more reliable for delivering nutrition than NG feeding, and risk of aspiration is low with small bowel feeding. So gastric feeding is not superior than jejunal or duodenal feeding. Now we come to gastrostomy. So indication. So if there is an impaired swallowing mechanism like some esophageal disorder, oropharyngeal or esophageal obstruction, major facial injury. What are the contraindication? Ascites, especially for PEG, coagulopathy, gastric varices, gastric neoplasm, or lack of suitable abdominal site for taking out the gastrostomy. Advantages is bolus feeding is possible, large bore tube. These are two advantages. Complication could be aspiration, bleeding, perforation, dislodgement, peritonitis, surgical site infection, necrosis. These are some of the complications. Most of the tubes which are 18 to 24 size can be used for around 12 to 24 months, and there is decreased risk of clogging. So what are the other methods? That are percutaneous endoscopic gastrostomy, that is PEG, fluoroscopic gastrostomy and surgical gastrostomy. In PEG, first we insufflate, distend the abdomen, stomach. Then through the endoscopic transillumination of the anterior abdominal stomach wall against the anterior abdominal wall, we pass a catheter across the anterior abdominal wall through the guide wire, through which the guide wire is threaded into the catheter. Then the guide wire is pulled out through the mouth and PEG tube is threaded and brought out through the abdominal wall and is fixed. We keep for passive decompression for 24 hours, then after we start using it. Then we have fluoroscopic gastrostomy, where we go for blind placement using the needle and T-prongs to anchor the stomach after insufflation stomach against the anterior abdominal wall. So we insufflate the stomach against the anterior abdominal wall, फुला देंगे stomach को, then blindly we place the needle and T-prongs to anchor the stomach and fix it. Then we have surgical gastrostomy, which requires GA, laparotomy, and method uses STAM method, where we can secure the tube with purse string or Malicot catheter with balloon tip. Gastrostomy it can be used for decompressing stomach in gastroparesis and gastric outlet obstruction. Gastrostomy PEG tube can be converted to transpyloric feeding tube through PEG jejunostomy. Now we'll be seeing jejunostomy. Jejunostomy, it is used for long-term feeding, especially in patient with gastric issues, gastroparesis, gastric outlet obstruction or reflux aspiration risk. It is performed as an adjunct to complex abdominal surgeries also. So what are the contraindication? Absolute is distal intestinal obstruction is the absolute contraindication. relative is severe bowel edema, radiation enteritis, IBS, inflammatory bowel disease, ascites, IBD, sorry. So severe immunodeficiency, bowel ischemia. So these are some of the relative contraindications. What are the disadvantages? Migration, displacement, peritonitis, fistula requiring continuous infusion. These are some of the disadvantages. Complications could be pneumatosis intestinalis, small bowel necrosis resulting in perforation. Other contributing factor, hyperosmolar solution, bacterial overgrowth, result in bowel distension, decreased bowel perfusion. So even shock, vasopressin, critical illness will cause further aggravation of bowel perfusion, decreased bowel perfusion, abdominal distension and cramps. Now endoscopic jejunostomy, that is peg jejunostomy, where the advanced gastrostomy access beyond the ligament of threads, or direct percutaneous endoscopic jejunostomy, where we use enteroscope or colonoscope to reach the jejunum, special scopy, and requires complex video endoscopic skills. It has variable success, and here we use needle jejunostomy. Surgical jejunostomy with the Witzel technique, where 15 to 20 centimeter distal to the ligament of threads. Loop of jejunum, which is good, mobile, tension free. Here where we oppose it to the anterior abdominal wall, tube is introduced and fixed via purse string, then through a serosal tunnel of around 6 to 8 centimeter, following which we fix to the parietal peritoneum and fix to the skin. Stam is similar in the gastrostomy, and here we do not go for seromuscular tunneling. So now we'll be seeing the enteral formulas which are considered while choosing enteral formulas, some considerations. So what is the functional GI status? How is the GI tract? Is it functional? Other organ dysfunction like liver or kidney, nutritional status of the patient and the requirement. So various enteral formulas. The first one is the standard polymeric formula, where we have 1 to 2 kilocalories per ml. It is useful for normal GI patients and stable patient. Daily requirement is up to 1.5 to 2 liters. Here we have baseline carbs, protein, fats, electrolyte, water, fat soluble vitamins, and nutrients like micronutrients. Here there is no fiber, minimum residue. Then we have caloric dense formula suitable for patient with requiring fluid restriction. Here we have increased kilocalorie per ml, that will be around 1.5 to 2.5 kilocalorie per ml. Higher osmolarity, so it is suitable for intragastric feeds. Then we have immune enhancing formulas which contain glutamine, arginine, omega-3 fatty acid and nucleotides, which is helpful for anti-inflammatory and antioxidant support. Fiber containing formulas which help in delay transit time, like condition of diarrhea, decreased diarrhea. So these will be helpful. Gut microbiome friendly prebiotic, these contain prebiotics, so it will be gut microbiome microbiota friendly, and colonocyte metabolism. So these are fiber containing formulas. Then we have high protein or bariatric formula. So part of high protein hypocaloric feeding regimens is useful in the critically ill obese patient, where we use 1 kilocalorie per ml, but we have 37% of protein. Then we have elemental formula for pre-digested, which contains pre-digested nutrients in the form of small peptides. It is especially useful for malabsorption, gut impairment and pancreatitis. So GI dysfunction, malabsorption, gut impairment and pancreatitis. Then we have renal failure formulas, where it will be having decreased fluid volume, decreased potassium, magnesium and phosphate, and essential amino acids. Then we have hepatic failure formulas which will have branch chain amino acid like leucine, isoleucine and valine. So that will be more, and less number of aromatic acid amino acids. It will be helpful in hepatic encephalopathy. Now we see the complication of enteral nutrition. So commonly it could be diarrhea, which could be due to infection or antibiotics, increased osmolarity of the feeds, acquired lactase deficiency or medication. So how do we treat them? Rule out infection if there antibiotics, fiber supplements, decrease osmolarity, decrease infusion rate, anti-motility drugs like loperamide and codeine that can be used sometimes. Nausea and vomiting due to delayed gastric emptying And constipation, so we can use prokinetics like cisapride. Constipation due to dehydration or decreased fiber, we can treat with help of fluids and fiber. Aspiration due to delayed gastric emptying, reflux or prolonged supine position, altered mental status. Treatment will be, we'll head up, stop the enteral feed. In case of gastroparesis, treat pneumonia, electrolyte disturbances, dehydration, hypernatremia, overhydration, decreased sodium, and hyperkalemia. So there could be electrolyte disturbance along with it, dehydration, hypernatremia, overhydration, decreased sodium. Hyperglycemia, increased carbohydrates, insulin resistance. There could be re-feeding syndrome, that is refractory hypokalemia, hypomagnesemia, and hypophosphatemia. Cause could be transition from fat metabolism to carbohydrate metabolism and abrupt increase in insulin in the body resulting in electrolyte disturbances, which may result in arrhythmia, neurological disturbances, renal or hepatic failure. So here treatment would be start low and go slow. So we have to slowly start the carbohydrate nutrition through the enteral formulas. So you have to be careful with that. So this was all about enteral nutrition. So now we'll be seeing parenteral nutrition. Parenteral nutrition involves IV infusion of nutrients in an elemental form. So we'll be giving the nutrients in a very small elemental form, bypassing the normal process of digestion because of any reason, GI disturbance or malnutrition. So what are the indication for these? That could be malnutrition, sepsis, surgically traumatic injury. So patients with partial or complete GI dysfunction who are unable to digest or absorb sufficient nutrients, like in cases of intestinal obstruction, enteritis, fistula, short bowel syndrome, or chemotherapy toxicity. And patient with associated malnutrition, sepsis, surgery, traumatic injury. For critically ill or injured patients in whom enteral nutrition is not feasible, we go for parenteral nutrition. So parenteral nutrition could be two types: total parenteral nutrition, which is through central parenteral nutrition, or peripheral parenteral nutrition, which is administered via the peripheral lines, the peripheral IV line. So we'll see in detail the total parenteral nutrition, the delivery of entire nutritional requirement of the individual. Here we use the hyperosmolar solution, which contains around 850 milliosmoles per liter, where there is high dextrose 15 to 25%, macro or micronutrients, central venous access, long duration, that is 1 to 2 weeks. Generally it is used when we have to give parenteral nutrition for more than 1 to 2 weeks. Then we have peripheral parenteral nutrition. So peripheral parenteral nutrition administered via the peripheral line, it should be low osmolar, dextrose should be less, up to 5 to 10%, less of protein 3%. Some nutrients cannot be administered as they cannot be concentrated into smaller volumes. It is useful when we have to use parenteral nutrition for less than 2 weeks and not suitable for severe malnutrition cases. So what are the routes of access for central venous access, temporary or short term? Percutaneous subcutaneous line, percutaneous subclavian or IJV line, which is threaded into the SVC. The size is 16 gauge. For long term or home parenteral nutrition, we have peripherally inserted central line or tunneled central line through or with the subcutaneous port. Now we see the composition for these parenteral nutrition. So total caloric requirement is around 25 to 35 kilocalorie per kg per day. Considering 30 kilocalorie per kg per day for a 70 kg man, it will be around 2100 kilocalorie per day. normal daily body protein requirement is around 1.5 gram per kg per day. So for a 70 kg man, it would account to around 105 gram per day. Protein containing calories, 1 gram protein contain 4 kilocalorie. So 105 gram protein will contain 420 kilocalorie. And we have to remember that 20% of the total caloric requirement is normally given by lipids. So 2100 into 0.2, that will be around 420 kilocalories. So each gram of fat gives 9 kilocalories. So 420 kilocalories will be given by 47 grams. And then the remaining will be given by the carbohydrate. Like we saw that total is 2100, 420 for proteins and 420 for lipids. So the remaining 1260, which will be given by carbohydrate, and each gram of carbohydrate gives 3.4 kilocalories. So 1260 kilocalories will be given by 370 grams. Now considering the available percent stock solution, how are these solutions available for peripheral nutrition? So carbohydrate which contain D-glucose or dextrose is available in the 70% stock solution. So if 100 ml contains 70 gram, so as we have seen, we need 370 grams. So for 370 gram, we will be needing around 530 ml of solution of containing carbohydrate, glucose. Protein solutions are available as 10% stock solution. So it will be having 100 ml will be having 10 grams. So 105 gram we will be needing around 150 ml. And lipids generally available as 20% emulsion. So 100 ml will have 20 grams. So 47 gram will be needing around 235 ml, 240 ml. So the total volume will be around 1800 ml per day. We have to consider the fluid and electrolyte. So normal fluid needed for the body is 30 to 40 milligram ml per kg. Sodium potassium will be 1 to 2 milliequivalent per kg. Calcium will be 10 to 15 milliequivalent per, and magnesium 8 to 20 milliequivalent, and 20 to 40 millimole of phosphate. We have to add some needed vitamins. So these are the normal requirement and composition of the TPN, peripheral nutrition formulas. So how do we initiate? In the first week of peripheral nutrition in the critically ill, first we give less, that is around 80% of the caloric requirement. That will be hypocaloric, and it reduces hyperglycemia and insulin resistance and decrease chances of infection risk. Then we slowly step up. Insulin may be added to titrate glucose level to 140 to 1800 mg per dl. We also have to replace extra ongoing fluid losses. So insulin may be added to titrate glucose level to 1400 to 1800 mg per dl. So we have to maintain glucose level around that so that infection is prevented. Now we see the complication of parenteral nutrition. So technical complication, that could be central line related, dislodgement, infection, or blockage. Bloodstream infection, which could be highest with the femoral line, lowest in the subclavian line. Indwelling time, that is resulting in infection. So if it is for 3 to 7 days, there is 3 to 5% risk. In more than 7 days, then it is 5 to 10% risk. Then complication related to central line insertion like pneumothorax, hemothorax, sub-artery injury, bleeding, thoracic duct injury, arrhythmia, air embolism, thrombosis. Then we have some metabolic complications, that is hyperglycemia due to hyperosmolar solution, diabetes, insulin resistance, stress will result in hyperglycemia. So here we have to treat with volume replacement, electrolyte correction, and insulin as per need. Respiratory disturbances, increased caloric infusion will result in more carbon dioxide and result in respiratory insufficiency. Then third one is the refeeding syndrome, which is seen in starvation and alcoholics, when metabolism shifts from lipids or protein metabolism to carbohydrate metabolism after feeding. There's increase in insulin, abrupt increase in insulin, resulting in decreased potassium, magnesium and phosphate, which result in multi-organ dysfunction, cardiac, respiratory, liver and renal. Then intestinal atrophy resulting from the parenteral nutrition due to lack of intestinal stimulation. We will see mucosal atrophy, mucosa of the intestine becomes atrophied, villus height is decreased, the bacteria in the intestine which are dangerous can overgrow, there will be decreased lymphoid tissue, decreased IgA production resulting in bacterial translocation and possibility of infection and sepsis. So we have to try for giving at least small amounts of trophic or enteral feed whenever possible. So this was all about parenteral nutrition. Hope it has been understood. See you in next video. Please like, share and subscribe. Keep studying, keep growing. Thank you.